Welcome to this webinar on transgender medicine by Dr. Nick Gorton. This webinar is being offered by the San Francisco Community Clinic Consortium and the California Statewide AHEC program in partnership with the Office of Statewide Health Planning and Development, designated as the California Primary Care Office. Funds for this webinar were provided by the U.S. Department of Health and Human Services, Health Resources and Services Administration, with American Recovery and Reinvestment Act funding, for a National Health Service Corps and State Loan Repayment Program Retention and Evaluation Activities Initiative. Dr. Nick Gorton is an openly gay and transgender physician. He completed residency and chief residency in emergency medicine at Kings County Hospital in Brooklyn, New York in 2002 and became a diplomat of the American College of Emergency Physicians in 2003. In addition to his day job in the ER, Dr. Gorton volunteers every week as a primary care provider focusing on transgender patients at Lyon Martin Health Services in San Francisco. Dr. Gorton lectures on transgender health care at medical schools and medical education conferences. He serves on the executive committee and is a lecturer and medical consultant for Project Health in San Francisco. He has worked as a medical consultant regarding transgender health care at the Lambda Legal, the Transgender Law Center, the Northwest Justice Project, and the New York Legal Aid Society and Sylvia Rivera Law Project. He is an active member of the World Professional Association for Transgender Health. Dr. Gorton.
Can everybody hear me?
I hear you.
Great. Okay. So the first thing that I want to do is I want to talk about something that hopefully people confuse less and less, but the idea of gender identity. And your gender identity is your internal sense of yourself as male, female, or androgynous, or something external to that spectrum. That's a completely subjective thing. It's what the person says it is. So you can have somebody who looks very masculine whose gender identity is female. Your gender expression is sort of how you look, and so you look at somebody and go, wow, that person looks masculine, feminine, androgynous. That sometimes is the same thing as someone's gender identity, but especially pre-transition for trans people, it may not be. And they may be in a position where they're not really safe to express their gender the way they would like to. This is also obviously different from biological sex, and a good way to think about that is your gender identity is inside your brain. Your gender expression is what you tell the world. Your biologic sex, it points to your genitalia, but it's also the chromosomes, the hormones that are around your body, and those physical things that we mark as sex. And then sexual orientation is totally different for all this. So you can have someone who sort of ends up parsing out wherever. So I'm going to use myself as an example. I am a transgender man, and my identity is male. Does everybody see that little arrow I pointed? I hope.
Yes.
Okay, good. And now my gender expression, if you talked to me 15 years ago, would have been over here. So, well, actually more like here. And then now I'm somewhere here. I'm a gay trans man, and I'm not entirely, butch masculine. My biologic sex is closer to here, as I was born here, but now because of things that I've done to cause physical changes in my body is moving over more towards the right, and then my sexual orientation is something totally different from those. So we expect those to correspond, but a lot of times they don't. So talking about primary care, the easy part is about this that you already know 90% of what you need to know, because almost all the medical care that has to do with trans patients doesn't actually have to do with them being transgender. You do have to manage hormones, but they have hypertension and asthma and depression and all those other things that you know how to do. And all of the medical treatments, all the hormones that we prescribe and all the other medicines we prescribe, actually you know how to use those because they were not, formulated originally for trans patients. All of them are used in non-trans patients, or cisgender. That's a term to define people who are not trans. The other thing, too, is we say, well, the surgery part's different. Yeah, the surgery part's somewhat different, but again, most of those surgeries were not developed in trans people. For example, phalloplasty, which is construction of a penis where one doesn't exist, was developed after World War II for soldiers who, had genital injuries and needed that. So that wasn't originally developed for trans patients. There's a lot of information out there, and I want to go through a few resources with you. The handout here that you can't really read because it's too small is Lyon Martin's sort of one-page front and back, the quick, easy to go to, what hormones do I give, what doses are appropriate, what other medicines do I give, what monitoring do I need to do, and you can have an electronic copy of this, I'm told, but then also if you forget about that, lose it, don't have it anymore, Lyon Martin and several other organizations, Transgender Law Center and some LGBT health clinics across the nation have collaborated to create something called TransLine, which is, it's sort of like the Warm Line is for HIV. Now, you're not going to get a live person, but we do answer questions within 48 hours, and it's designed for clinicians, obviously not for patients to ask questions. But on there, there's actually a bunch of resources, and that's one of them. So if you go to transline at Zendesk.com or transline.zendesk.com, you'll find that. You'll find a lot of other resources too, and if you have particular questions about patients, it's a safe place to get those answers in a relatively timely fashion. There's other stuff out on the web. The UCSF Center for Excellence in Transgender Health has their primary care protocols for trans patients, and those are quite helpful. They have other stuff on their website, obviously more than just primary care protocols, but that's certainly a good resource. It's older, but the information on it is still pretty up to date, and it's reasonably good information for providers. Is Vancouver Coastal Health has a transgender health program, and they put all their clinical protocols online. It's not just hormones, it's surgery, it's treating adolescents, it's social and psychological issues. The other good thing about their website is they actually have very good patient handouts. So if you go to their online library and you scroll down, you'll find all these patient handouts, like trans women and hormones, but they even have one that's trans people and vaccinations, which I never really understood what the difference would be, with the exception of possibly the HPV vaccine. But so they have a ton of information. They're very good handouts, and they're very readable for patients. So you have your resources in hand and somebody walks into your office. So how does this work? From the perspective of the trans patient, the first thing you do is you get to that point where the pain of changing is less than the pain of staying the same. So you say, I have to do this. It's too painful to not do this. And then you seek out help. It used to be local groups and organizations. Now everybody turns to the internet where you can find a wealth of information about this. And then at some point you realize, well, traditionally what you do is you find a therapist, and you are diagnosed by that therapist as having gender identity disorder. And then that therapist, after a duration of either psychotherapy or what's called a real-life experience, provides you with a letter that you take to a medical provider to start hormone therapy. Typically that was 3 months of therapy, but it was certainly to be determined by the psychotherapist in question. The real-life experience is basically you go out and you live full-time in the cross-gender role. And the reason, even since the second version of WPATH, which was, I think, when I was in like the 4th grade or something, it was always an either-or. The first version it was both, but the second version it was either-or, and that's because they realized that, one, not all trans people need therapy, and two, not all trans people is it for them to do a 3-month real-life experience. If you have a trans woman who's 6'6" and broad-shouldered and has a deep voice, and you say to her, well, tell you what, go out and live in your community full-time as a female, start wearing dresses, use the women's restroom, change your name, and if you're still alive in 3 months, come back and see us, and we'll see what we can do for you. That's totally unreasonable, obviously. Now, with the most recent version 7, they've gone even further away from that, and they don't like to. They still mention it, they still talk about it, but they don't specifically say, oh, you have to do this to get your hormonal treatment. But then at some point you find this medical provider, you start hormone therapy, and at the time you start hormonal therapy, that's when you can also access any surgeries as long as they're not genital surgeries. And again, this is according to WPATH standards of care. If you've done all this for a year and been successful and you're happy in your new role and everything's going well, then your provider could refer you for genital surgery. So that's the standard pathway. Does everybody do it? No. And if they don't, should you still treat them? And definitely in San Francisco, the answer is yes. But even anywhere you use the WPATH standards of care, the answer is also yes, because they explicitly endorse harm reduction. They say, the example they give is a trans woman who's getting hormones on the street and is injecting them with who knows what needles from whatever source she can get them for, and is doing it in an unsafe fashion. And she, the harm for her of giving her hormones that she's already taking, but in a controlled fashion with safe things and safe injection, is a lot less harm than the possible chance that this person who's already transitioning is inappropriate for transition. So they actually explicitly endorse that. So, when you see patients, the way I like to think about it is you really have to set their goals on something that's realistic. And the way I describe it to patients is the things that will happen, the things that might happen, and the things that won't happen. So, for example, if you're a trans man and I give you testosterone, you will get a deeper voice and you will grow hair on your face. You might go bald because testosterone does that, and no, you're not going to be able to get your girlfriend pregnant. And that's kind of a joking comment, but I actually had a patient ask me that. Would that be possible? The answer was no. So sometimes people's ideas of what will happen and what they've heard from their friends will happen doesn't parse to reality. So you have to make sure that you understand and they understand what they think is going to happen. The other thing, too, is you really need to emphasize primary and preventative care, because trans people, as a general rule, don't like to go to doctors and nurse practitioners and PAs, and it's because there's a long history of abuse and not letting people get access to care and making hoops that you have to jump through, and even sometimes just not providing care at all and letting people. There've been examples where trans patients have died because providers would not give them even non-trans related care. So that's there, and you may be the only person that your patient is willing to go see, so you have to do all the other stuff really, really well. The other thing is use the simplest program that will achieve the goals, but you have to know more than, you can't be a one-trick pony with this. Not every option works for every patient. Some people are needle phobic, some people, want injected, some people don't want oral, and you have to also factor in cost, because a lot of trans patients pay for this out of pocket, and ease of use, and also safety, because there are differing regimens that have different medical safety. Though, interestingly enough, I'm going to digress for 1 minute here. The cost issue, especially if you're a provider in California, actually just got a lot easier. It announced today, literally, the Department of Managed Healthcare in California has followed suit of the Department of Insurance and basically, released rules that said that insurance companies, as they have previously, are not allowed to include in their policies exclusionary things that say, well, we don't treat any trans stuff, we don't do hormones, we don't do surgery, that you cannot exclude it as a rule. I mean, it's not reasonable to do that. That was actually due to the California Insurance Non-Discrimination Act, which passed in 2005 and was active after 2006, essentially globally says this, but DMHC and the Department of Insurance earlier this year released rules and said this is what we think that means, and so health insurers have to abide by those rules. They can challenge them in court, but the feeling that I get is they won't be challenged or they won't be seriously challenged. The good thing about that is that's going to basically mean that pretty much all commercial insurance in California is going to have to cover this. Add that to the fact that there is already, it's already the case that Medi-Cal covers it. There's essentially going to be 3 groups of people who will not be covered. That is those who are uninsured at all, those who have only Medicare, because Medicare exclude this still, and those who have federal insurance, which wouldn't fall under the California law. So that's actually really going to change that equation in a lot of ways. So it's very exciting news. But still, a lot of patients' cost is an issue, so know what things cost. I talk to patients about being patient about the changes. The problem is that no trans patient is actually patient when they come to your office because they want this 2 weeks ago yesterday. But I tell them, look at a pubertal kid. Look at a kid at 10 years old, then 11, and then 12, and then 13. These are very gradual changes that take years to happen. The other issue to think about is, for example, we would call baldness a side effect. Not necessarily. It's medicines cause effects. Whether or not they're side effects or beneficial effects depends on the patient and what they're taking it for. If you have a trans guy who's 4'9", has really large breasts, and he can't afford surgery, at least now he can't afford surgery, to get a mastectomy done, and every time he goes out in public, people say her and she and ma'am, that's really bad for that patient. If that patient starts going bald, that is an absolute clue to anyone seeing that person is a male. I don't care if you look like Dolly Parton. If you have male pattern baldness, they'll say, that's a dude dressed up like Dolly Parton. So that, in some patients, that's actually a beneficial thing. And my friend Shannon Mintner's case, he's not very happy with it, but I use him as a good example. So some of the fundamentals of treatment, the hormone treatments are actually really easy. Trans men are ridiculously easy. It's like add testosterone, stir, wait 2 years, and you're done. With trans women, it's a little bit more difficult because you have to suppress testosterone production in addition to adding androgen to get the best results. So in addition to adding hormones, you have to give anti-androgen. The other thing, too, is pre-orchiectomy, that is before people have at least that as a surgery, if not full vaginoplasty, you actually have to use rather large doses of estrogens. And part of that is to feminize, but also part of that is to adequately suppress the testosterone. In addition to the anti-androgens you use, a lot of times you need higher dose estrogen. Even once people have had orchiectomy, though, they oftentimes don't go to 1 time the normal replacement dose. And part of that is size. I mean, male-bodied people on average are bigger than female-bodied people, so they're still probably going to take higher doses, but usually not 5 times. So once your patient gets an orchiectomy, then your sphincter tone as a provider can go down a little bit because you're not giving them gigantic doses of estrogen. In the anti-androgen, spironolactone is probably the most commonly used one. It's cheap. It's reasonably safe, readily available. Orchiectomy costs about $1,200, and within a couple of years, your patients may be able to just get that anyway. The results of hormones that you take are very variable, and it depends on your age at which you start. Obviously, younger people do better than people who start later in life, and also genetics plays a big part. The options out there, oral estrogens, estradiol is ridiculously cheap. It's like on the $4 Walmart list, and it's available for like pennies at Costco and at through the Walgreens discount program. So there's a lot of different options for patients to get it. Premarin, while it's oral, is actually expensive because it's a branded formulation. The thing is, I actually push estradiol as a primary drug anyway if we're going orally because it is marginally safer for people, especially at those higher doses. Intramuscular is another option. It's the price is kind of in the middle range. It's not quite as much as transdermal, but it's still more expensive. Sometimes you can actually get patients to get it at a compounding pharmacy, and that might cut the cost about half. But it's there's some patients who prefer it, and if they want to pay the extra for it, it's fine. Or maybe their insurance now covers it. The big issue that I have is you can't, once you've given that shot, it's there for 2 weeks. So if your patient gets their shot on Monday and they fall and break a hip on Tuesday, you're not going to be able to stop that for a while. And so the risks of estrogen with immobilization might become an issue. Transdermal, this is actually the safest. I'm going to talk about a couple of safety studies later. But it's definitely the safest for trans women who are predisposed to thromboembolic events like DVTs and pulmonary emboli, especially if they're over age 40. That's a great option. If you're able to do it, it's usually difficult to get an adequate dose if trans women have not had an orchiectomy just only using the oral formulation. So what happens when you give estrogens? The breasts grow. Again, it also helps suppress androgen. Body habitus changes, like the muscle and fat move around, and the skin gets a little bit softer. The contraindications and precautions are the same ones as in cisgender women, so you know what they are. The one thing that I would say is that if you're talking about a cisgender woman who's postmenopause, who's just got hot flashes, and she also smokes and previously had a DVT, I probably wouldn't use estrogen in that case, because the benefit that we're getting is not, complementary to the risk. With trans women, especially because, untreated, trans people have a 20 to 30% suicidality rate in most studies, the benefits of this are much greater, and so correspondingly greater risks would be reasonable. So you have to do the individual risk-benefit analysis for your patient. And at the very least, in women with absolute contraindications, which, for me, it's mostly estrogen-sensitive cancer, then you can at least fully suppress the testosterone. This is a long list of things. The big one up there is thromboembolic disease. That we know definitively is a risk for trans women. The other ones are sort of theoretical, or decreased glucose tolerance has been demonstrated. But you can literally pull out your Palm Pilot and bring up estrogen and see all these side effects because you kind of know what they are anyway. The anti-androgens that we use, they all either decrease the production or the activity of testosterone. They're going to slow or stop male pattern baldness. They're going to slow unwanted hair growth and maybe make those hairs thinner, but it's not going to make your beard go away. Usually trans women have to use or have to get laser or electrolysis to get rid of hair on their face. It's going to decrease your erections and libido, and again, that's an effect. Whether it's a beneficial effect or a negative effect depends on the patient's perspective. If you are old enough, it might help your prostate hypertrophy. Like I said, spironolactone is the one that we use most commonly. It's cheap. It's reasonably safe. The big issues are potentially hyperkalemia, though I've had patients who even have mild to moderate renal insufficiency that have used spironolactone in, and as long as you start low and go slow, they usually tolerate it really well. The bigger issue that I've found is young, healthy, thin trans women who, are basically taking a relatively high dose of a diuretic, and then they go out and they go to Pride, and it's frying, and nobody's drinking enough water, and then they pass out. So the hypotensive effects of it can be one issue. The other thing is, too, some patients just don't like it, and just don't like it oftentimes might mean that they're having problems with their ability to maintain an erection and with their libido. And so asking them a little bit more about that, you might be able to help them still get good results, but manage the erectile dysfunction too. It's going to decrease your hemoglobin and hematocrit because testosterone is what causes your kidneys to release the hormone that tells your bone marrow to make red blood cells. So the important thing is to make sure that your trans women have that F marker on their lab slip, because if they don't, then you might think your trans woman is anemic when she's actually normal, and vice versa for trans men. Some other options, flutamide, cyproterone, I've had some patients who've used. It's not that I know of currently licensed in the U.S., but some patients do get it from out of the country. And then also the 5-alpha reductase inhibitors that are used, for prostate hypertrophy, but often now also for hair loss. So those decrease the conversion of the testosterone that you do have into dihydrotestosterone, and DHT is what causes hair loss, and it's actually a stronger androgen. Now, this alone isn't usually adequate for trans women, but used as in addition to some of the other anti-androgens, can be helpful. I put Costco's prices up because they actually let you look them up online and they publish them. But I mean, that's the kind of range. I always prescribe the 5 milligram tablets and tell them to get a pill cutter, because they may not need 5 milligrams, 2.5, or even 1.25 might be reasonable. But because the 1 milligram dose is used for hair loss, we charge more per pill for a 1 milligram pill than for a 5 milligram pill. Kind of be notice what your patients are paying for things. So how about monitoring? They come back to the office. I mean, this I really shouldn't even have to tell you about, because you know how to do this. People check their blood pressure. Are you safe? Is anybody hurting you? Feeling depressed? Let's do a PHQ-9 or a GAD-7. And all those general screenings that you do based on their age, the organs that they have, and also gender and sex-appropriate norms. So when patients come in, especially the trans women, I make sure they know what a DVT and a pulmonary embolus looks like. But again, healthy habits, we talk about everybody with that. The other thing, too, because you're giving high doses of estrogen, that I'll talk about in a couple slides, is vision changes or lactation. Clinical monitoring, so doing the blood pressure check, is more important, and looking at your patients and talking to them, but we are all providers, so we like to send labs. So, typically 0 to 6 months post, and then either annually or semi-annually after you change dose for something, you would check a CBC, a comprehensive metabolic panel, lipids, prolactin, and sometimes testosterone in trans women if you're trying to see if you're getting adequate treatment. The reason you do the CMP, you can cause transaminitis with oral estrogen. If they're on spironolactone, you want to check a potassium and creatinine. It does impair glucose tolerance, so checking a fasting glucose every so often is useful. Prolactin, I'm going to discuss on the next page, but basically, you look at all these to help you, in addition to looking at your patient, figure out, are they having adequate outcomes? And those are all the clinical things, but from the lab perspective, the floor is testosterone level. So if a trans woman's testosterone is in the normal female range, adding more is probably not going to be more beneficial. The roof is typically the prolactin level. I'd love it to be under 20. I'm okay with 25, even up to 30. Over 30, I start watching it. And you ask patients, are you taking Reglan? Are you taking a psych medicine that causes elevated prolactin? If it's over 50, I worry a lot about the patient perhaps getting a prolactinoma. But typically you don't see those till it's over 100. Most prolactinomas will have a prolactin level over 100. And so the problem with prolactinomas is if you give high doses of estrogen, it stimulates the anterior pituitary to produce more prolactin, and that can cause an adenoma, a non-cancerous growth, which, it's not cancerous, but the big problem is the optic chiasm, which is the nerves that, transmit what your eye sees to the back of your brain so it can be processed into understanding what's in front of you, can be squished by that tumor. And so people who have a prolactinoma are at risk for blindness. So you need to look for prolactin, but that's also why you would ask patients to report vision changes or report any lactation, because that can be a sign of an elevated prolactin level as well. If people have that and their prolactin is too high, either stop or at least decrease the estrogen and see what the prolactin does. If it goes down and it goes under a normal range, great. If the levels remain high, especially if they're increasing despite stopping estrogen, you need to do an MRI to make sure they don't have an adenoma there. Elevated LFTs, again, with oral estrogens, this is an issue, but to be honest, I've never seen it as just from the oral estrogen. It's usually estrogen plus they have viral hepatitis, or estrogen plus they're taking another medicine that causes transaminitis, or they're drinking, or something else. So look for those other causes. Don't say, oh, this elevated LFT is probably just the estrogen, and not go off and look for the other issues that your patient's going to have. If you do find that it's partially due to estrogen, you can either lower the dose or stop it until the LFTs return to normal, or consider decreasing the dose or counseling them about alcohol if that's the issue to, in other ways, treat that. So trans men, it's even easier. I like this cartoon. So after years of intensive research, we finally have a clear picture of testosterone action. It hits a receptor, then something happens, and you get effects. And that really is kind of a summary of what happens with trans men. It's like I said, it's add testosterone, stir, wait 2 years, and usually get very, very good results. Oftentimes much better results than you get in trans women. The most commonly used formulation is the injected esters. Of the two, testosterone cypionate's cheaper if you buy it, pay for it out of pocket. Testosterone enanthate is a little bit more expensive. The other issue too is the vial size is a little bit different. Now I'm going to try to open the next set of slides because it's broken up into two, and that worked. So there's really clinically not that much different between those two. Some patients have a strong preference for one or the other, and it really doesn't matter to me because they're clinically very similar. So with trans men, there's not nearly as many problems. When you are checking testosterone levels, this is the case for every drug, you achieve steady state after 3 to 5 of the half-lives. For the esters, that's about 8 to 10 days. So basically it's about 2 months. So if you're checking a testosterone level, you want to check it after they've been on whatever dose they're currently on for about 2 months. The single most important pearl for trans men is that second picture down. So the side effects that trans men get if they're taking injected esters usually happen up here at the peak or down here at the trough. So, at the trough, oh, my energy's really low. At the peak, my face looks like an oil slick or whatever. My libido goes higher than I would want it to go, right? So if patients have that, what you do is you decrease the dose and give it twice as often, and you get this curve, which has lower highs and higher lows. That often fixes just about everything. So maybe instead of 200 milligrams every 2 weeks, you would give 100 milligrams every week or 150 every 10 days, and that usually helps a lot of the problems. Transdermal is also an option. It's really expensive if you buy it retail. It's much less compounded. There's a pharmacy that I use, and I have no financial interest in them, and the only reason I mention them is because a lot of my patients use them, and they're very trans-friendly. That is, if you're writing Mary Smith a prescription for testosterone, they're not going to hassle Mary Smith about it because they kind of know what that's for, especially since this testosterone is a controlled substance. There may be an issue for your patients. They go into a regular pharmacy. They say, wait a minute, you're a woman and you're taking normal replacement doses of this, especially early in transition. And so they're very cool about that. And they're also cheaper for the transdermal. The benefit of that is the levels that their testosterone levels are much less variable. The problem is you have to mess with it every day. And the big risk is you may inadvertently transfer it to others. The biggest risk is if the other in question is either a child or a pregnant woman, because there have been cases of, daddy takes androgel and he doesn't wash his hands really well and then picks up his toddler, and then the toddler starts growing pubic hairs, right? So there is an inadvertent risk of transfer. So you have to make sure your patients know how to put it on correctly, which is basically come out of the shower, dry off, put the topical on a place that is going to be covered by clothes. Oftentimes people use their chest or their belly. Make sure it completely dries, then put your T-shirt on. And after 4 hours, you can have what the manufacturers of one of the brand name ones refers to as vigorous skin-to-skin contact with somebody without risking transfer. So after 4 hours, you're pretty safe with that. Trans men, this is almost the same slide as trans women, and again, I don't have to tell you to ask patients about safety, how are you doing, what's your blood pressure at every visit. With trans men, asking them about vaginal bleeding, especially if it's been a year since they stopped their periods, and then also if trans men are getting acne or they're getting male pattern baldness, those can, they're some people in the trans community are like, well, that's just the cost I got to pay for this. No, not really. There are treatments that we have, and you should offer that because trans patients may not bring it up. Especially trans men, for some reason, tend to get a lot of chest and back acne, and that's even after they have had chest surgery, so they're not having to bind anymore. But especially trans men that bind their chest before they've had mastectomy, so that they can pass better in society and people don't see large breasts. They're going around in the summertime with their breasts squished to their chest as tight as they can get them, and there's sweat under there, and I've seen patients with just the most raw, red, angry-looking yeast thing or acne that they didn't mention to me until I asked, because trans men are usually, well, not that some of them are fine with it, especially with their provider, but there's this, disinclination to show people your chest before you've had surgery, and so they may be reticent to do that, so you got to ask them about it. Again, clinical monitoring is the most important thing, but we all like numbers, so we send lab tests off, and this is pretty similar to the trans women, and except there's nothing actually highlighted, and that's because rarely are there any problems. Hemoglobin and hematocrit are going to go up. Creatinine might go up a little bit because you're growing more muscle mass. If you are going to, or when you do check, you should check testosterone every so often. You should check it at trough, which is right before their next dose. In the case of transdermal, doing it in the morning before they put on their daily dose is a good way to do it. So what happens in the first 6 months, you get acne like you cannot believe, your sex drive goes up dramatically, and, is that a beneficial effect or a side effect? It depends on the patient. If you're in a 15-year committed relationship with your female partner and you guys have sex 2 days a week and now you want it 2 times a day, that might be something that causes problems in your relationship. The voice changes start to happen and be noticeable, and you're going to sound like Greg Brady when your voice cracks, and you're going to go through that adolescent voice period, which everybody's like, oh, that's funny. Yeah, except unless you're a trial lawyer. Or in my case, I transitioned when I was an ER physician in Louisiana, and they were like, why is the adolescent resuscitating grandma? So if that is a problem for your patients, you could actually send them to speech therapy. Hair growth is going to happen, the hair growth that you want on your beard, but also from your ears, your unibrow, your back. It's what genetics gives you. You start noticing clitoromegaly. Most trans men are amenorrheic by 6 months if they're on moderate to high dose, but despite the fact that estrogen actually only goes down modestly, it usually doesn't go down to the male range, but that's okay because it doesn't need to. You're not trying to get a certain range of hormones, you're trying to get physical changes in your patients, and because trans men, the physical changes are much easier to achieve with testosterone, you don't need to suppress the estrogen. And then metabolic changes start. By about 5 years, the voice is finally settled, you're going to get your final fat and muscle redistribution. So certainly if you go from being athletic to a couch potato, that's going to change too. Clitoromegaly maxes usually by 2 to 5 years. It's not big. It is more if you start in adolescence, and usually surgeons who are going to use the hypertrophied clitoris in constructing a phallus, so doing a metoidioplasty, which is that surgery, usually want patients on hormones for at least a couple of years to sort of get the maximum out of it that you're going to get. 5 to 10 years, you finally get that final hair growth, and it literally can take 10 years for a beard to go where it's going to. You certainly at any time can get androgenic alopecia, and it's as common in trans men as it is in cisgender men, though you can treat it the same way. You can give trans men finasteride just like you might give to a trans woman with baldness issues, because it works just the same. Most common, all these side effects here you can look up on your Palm Pilot of choice. The biggest thing is the acne, which we talked about. Cardiovascular surrogate endpoints do worsen, and everything that we've talked about already. Again, make sure you put the M down on the lab slip, or you might find that your patient looks polycythemic when they're not really. So is this safe? There's not a ton of good studies from the U.S. for many reasons that I won't go into, but there's actually some pretty good data from Europe. The Netherlands has a great opportunity to do this because there's really one clinic that is the referral center, and they treat almost all the Dutch trans people, and this is also the Netherlands, and so they have cradle-to-grave records on everybody, so they're absolutely, this is a great natural study that you can perform. So the first big publication they did about this was in 1997, and basically they just looked at morbidity and mortality outcomes compared with the general Dutch population. And those numbers for trans people are not really high, but for a trans study, this is as big as Framingham is. So this is a big study for trans people. So they looked at trans men who were female-bodied people and compared them with cisgender women, and they looked at trans women and compared them with cisgender men, and what they found out was that the total mortality was no higher than the general population, and most of that mortality had nothing to do with hormone treatment. The big complication, and this was much more frequent in trans women, was venous thromboembolism, but after they started doing transdermal estrogen for all their trans patients over 40, the cases of that dropped precipitously. In fact, as of their publication in 97, I think they had only one patient who got a DVT on transdermal, and that was somebody who had a DVT, and they said, well, you can keep taking the estrogen, but you have to take Coumadin to thin your blood, and she said, great, no problem, and she stopped taking the Coumadin and continued the estrogen, so she got another DVT. In trans women, there was also an increased morbidity from not just the blood clots, but HIV disease, and there was an increase. The overall mortality was no different, but there was an increased proportion of mortality that was due to HIV and venous thromboembolic disease. So for trans men, no change in morbidity and mortality. For trans women, the mortality was not increased, but there was more HIV and venous thromboembolic. Another study, again, a cohort, again from Europe, a few more patients on this. They'd been on it for a median of 18 years. This is a pretty long-term outcome. In trans women, they actually found that the mortality did increase, but that was almost entirely due to HIV and suicide. And those are things that are not the hormone's fault, right? So HIV is about behavioral things and protection, and trans women are disproportionately vulnerable to that in Europe and in the United States. Though in the United States, while it's not due to hormones, it is due to a lot of structural problems in society, and the fact that if you're trans, you may not be able to get another job, so you may have to turn to the street economy, to narcotic sales, or to sex work, which puts you at disproportionate risk for that. And then the suicidality, yeah, that's an issue in trans patients, but the thing is, all the studies that we've done of it decreases significantly when you actually provide care to patients. So while there was more suicide, it was less than you would expect if you had not treated them, and in their study for trans men, the mortality was unchanged. So the Dutch group republished again in 2008, and again they looked at morbidity and mortality data. This time they had a lot more patients. They had over 3,000 patients, and had added, up to 10 years more life experience for their patients that they had in 1997. And so they looked at the morbidity and mortality, but also they looked at, small studies they would do where they would look at cardiovascular risk markers in this 100 trans people that we did, and they also looked at hormone-sensitive tumors. For cardiovascular risk, basically what they found was that surrogate markers get worse in both groups, in and trans women, though not in the same way, and trans women tend to do a little bit worse from the surrogate marker perspective, though not everything worsens. For example, in trans men, while your glucose tolerance gets worse, your fasting glucose also is lower, so not everything is worse. The hard clinical endpoints as of that 2000 and I think it was 2008 or 9 study, they hadn't found any difference in the hard clinical endpoints, though they subsequently published, or they subsequently presented at a WPATH conference that they had reached a hard clinical endpoint for cardiovascular disease in trans women. So the thing is, it probably does increase your risk, but again, it's a risk versus benefit question, and sometimes you can motivate people and say, hey, you're adding a cardiovascular risk factor, let's work on your other ones. Again, another cohort study, this is just about cardiovascular risk, and this actually was a meta-analysis of the studies I talked about previously and other ones, and they found that both groups had increased triglycerides. There was a minor, statistically significant but not clinically significant effect for trans men having increased blood pressure. They did not find a hard clinical endpoint correlation, and most of the events, though, were in trans women. So, and they also said most of the studies out there are not great quality, but in total, the stuff that was out there as of 2010 said no hard clinical endpoints, but, my perception of what the truth in the universe is it probably does worsen it, though it's not probably a huge effect. What about hormone-dependent tumors? Prolactinomas are pretty rare, but you shouldn't miss one. Prostate cancer is a possibility, and the thing is, even with trans women who have surgery, the prostate is usually not removed. So you should screen based on the organs that are present, but we know that prostate screening is one of those things that seems like a good idea and doesn't really help in many parts of the population. The other issue with trans women is that if you're taking estrogen, that may falsely lower your PSA, so it makes a crappy test that's not good in most people even extra crappy, so just keep that in mind. Breast cancer, in both, it's a risk. For trans women, it's all about the dose and duration. So if you started taking hormones at 50, at 52, you're probably not at huge risk as long as you don't have a big family history of it. The most conservative idea is just screen like cisgender women of the same age and risk. That's pretty conservative, and you're probably going to be doing a lot of screening that you don't need to. A good recommendation, and this is sort of general consensus recommendation, is that if trans women are over 50 and they have one of the following risk factors, they're obese, they have a family history of breast cancer, they've been on any hormone therapy for more than 5 years, or chest radiation increases risk in everybody, and also if they're taking progesterone, but especially if they've taken cyclic progesterone in the past, you probably should screen them. In trans men, it's more rare because a lot of trans men get mastectomy, but the mastectomy that is done for cosmetic reasons is not the same as a mastectomy that you would do prophylactically for a woman who's a BRCA gene mutation carrier. So there's more breast tissue left. The other thing too is even if you've had an oophorectomy, some of that injected testosterone is aromatized to estrogen. So, while you can't do a mastectomy on a breast that's no longer there, you can tell patients, hey, pay attention if you find the lump, come and tell me. What about gynecologic tumors in trans men? This is what everybody worries about. The big one that everybody's scared about, because it's a no-see-em that will generally kill you by the time it's discovered, is ovarian cancer. And people ask, well, what's the risk of a trans man? Is it increased, decreased, or unchanged? And the answer to that question is, I don't know, neither does anybody else, and we're not going to, because it's a small population, it's a rare tumor. Many of these patients are lost to follow-up. Many of them have an oophorectomy anyway. I know of 6 cases in the literature, plus Robert Eads, that's 7 in the numerator. How many more in the numerator? How many in the denominator? I don't know, so I can't really do that. And nobody else can either. It's important to tell patients if we don't know, we don't know. How about endometrial cancer? This is we know that trans men have a little bit more hyperplasia if you look at after hysterectomy. We also know that cisgender women who have PCOS, especially if they have infrequent periods, may have an increased risk for endometrial cancer. And we also know that trans men are more likely pre-treatment to be diagnosed with PCOS. So it's sort of like Colonel Mustard in the library with a candelabra. There was a better study that looked at this more directly, though, that came out in 2010. And basically they took 104 trans men and looked at their uteruses after hysterectomy. These tend to be younger people. Their population was obviously younger than usually people who get hysterectomies, which is kind of middle-aged women and older. So they found atrophic endometrium in 50. That's great. 54 were still proliferative, and that's with patients on testosterone. 4 polyps, 8 hyperplasia, and 1 dysplasia with a small focus of carcinoma in situ. That's more than you would expect to get. So what the risk is, again, is a little bit more evidence that it's probably increased. And so what I tell patients, and this is with cisgender women too, postmenopausal vaginal bleeding is cancer until you prove it otherwise. Now, only about 25% of postmenopausal vaginal bleeding is cancer, but 25% of postmenopausal bleeding is cancer, so you need to prove that. With trans men who've been on hormones for more than a year, they should look postmenopausal, right? So they shouldn't bleed. If they do, the first thing I say is, oh, did you stop your testosterone? Did you miss a dose? If that's not the case, you need to work it up similarly. How about cervical cancer? This is one of those things in medicine. We've done amazing work. We have reduced the risk of cervical cancer 95% nowadays, which is great because it used to be a huge killer for women. The problem is it's hard to get cisgender women to get screening as appropriate. It's harder to get lesbian women to get screening as appropriate, and it's like herding cats to get trans men screening at appropriate intervals. But you have to do that, and you have to be good at that. The reason being that, we look over here, it's 2003 data, but it's pretty reasonable. Lung cancer, breast, colon, rectum, these 2 lines are ovarian and pancreas, and down here you have uterine cancer, which is endometrial plus cervical cancer. The thing is, if you go up here to before the esteemed Dr. Papanicolaou came up with a cervical cytology smear, it was the #1 cause of cancer death in women, and they tended to die. So you really need to do this for your patients and emphasize that, because while they may be worried about the ovarian cancer, it's cervical cancer that's going to do it to them. So is it effective? This is the one best study that's out there. Basically, they looked at the 28 studies that met their criteria, 23 of which, though, included surgery. 5 were just psych and hormone treatment. Pre-treatment suicidality was about 30%, went down to 8% post-treatment. That's a profoundly effective treatment. Significant improvement in sort of measures of gender dysphoria and measures of psychological functioning. In one study that actually included surgery, people were on another study or in another assessment of psychological functioning. Trans patients were in the non-clinical range, so it's as though there was no mental health problem there once they were treated. The few studies that looked at employment and financial status, it improved in all of those. So what about regret? Basically, the regret risk is tiny. It's really, really small. And if you compare it to other sort of semi-elective treatments like gastric bypass and, breast reconstruction, which have 15, 20, 25% regret rates, yeah, a regret rate of 1 to 1.5% is pretty darn low. The last thing I'm going to talk about really briefly is helping your patients with their identity documents. And this is part of the treatment for people who have gender identity disorder. Because if you're providing hormone treatment, if you're providing surgery, and you don't help people with their identity documents, I think you're committing malpractice, right? Because you're putting somebody in a position where they're vulnerable to a lot of things. 1, interpersonal violence if they have to use identity documents that don't match. But 2, they may not be able to get a job or change jobs. They can't use a credit card. They can't board a plane. They may not even be able to go into a federal building to apply for entitlements, which they're eligible for. And the thing is, if you're getting on a plane, they might hassle you a little bit. They're probably not going to beat you up. But the problem is trans people who don't have adequate identity documents voluntarily withdraw from these activities. So they don't do those things because they're too hard. And when they do that, they kind of slip into shadow economies or they stay with the crappy job with no insurance because it's too scary to do otherwise. The thing is, you can do a tremendous amount. In California, if patients haven't had surgery, that is, they've just had hormones and they socially transition, they can get a change in their driver's license. From a federal perspective, they can get a passport. You can get a court-ordered name and gender change if you have a California birth certificate, and some other states, because like if you get a court-ordered name and gender change in California, you can get your birth certificate in Texas changed, right? You can get your name changed on Social Security, but their gender marker still has a surgical status, though there have been patients who take a non-specific letter and they change their gender anyway. That's sort of, it's not great. risk, but it's not horrible risk either. So some patients, if they know they're not going to be able to access surgery, they may just say, I'm going to try. The good thing is when you're writing letters for people, for providers, there are no gender cops. I've been writing all kinds of letters for the past 8 years, and not once have I been questioned about any of it. And your job in this is to advocate for your patient's needs. You can't lie, but you can give your real medical opinion. And the thing is, don't write something if you don't know how to do it. If you need to know how to do it, email me or the Transgender Law Center, and we'll give you the boilerplate. So I'm going to use a very quick thought experiment to get you to the idea of why you should do this. So you're a doctor in North Carolina in 1950, an 18-year-old young man who's been your patient since he was a baby, asked for your help. He's white, but his great-great-grandfather was African-American, and I can say this because I went to UNC, so I kind of know history. He was accepted to go to Chapel Hill, but an anonymous letter to the school revealed his heritage, and he was told he has to actually provide a letter from a teacher, a doctor, or a minister verifying that he's white to go to UNC. So you're pretty advanced for the 50s, and you understand that race is a social construct, and from that perspective, he really is white, but you also know that UNC's policies and their understanding of race would exclude him. Do you write the letter? Obviously. And do you write in the letter, well, his great-great-grandfather was African-American, however, my understanding of race is that it's this, and blah, blah, blah. No, you just say, I delivered him, he's my patient now, he's white, and that's it. That's the end of it. So the same thing with trans patients. So, like I said, there's no gender cops. As long as you're telling the truth, you're protected. So I'm a physician licensed to practice medicine and surgery in California. Now, am I a surgeon? No, but if you're a doctor and you look at your license, it says medicine and surgery, so that's a truthful statement. And the person reading the letter might go, oh, this is a surgeon. If they just don't know about the laws of California, that's their problem, not mine. John Smith is a patient of mine. In my medical opinion, he's transsexual. I've determined that his male gender predominates, and I've provided him with appropriate and irreversible, keyword irreversible, sexual reassignment treatments. And if he has had surgery, then I say he's had irreversible sexual reassignment surgery. I don't say he's had a mastectomy or she's had, facial feminization surgery. I just say irreversible sexual reassignment surgery. Again, let the person interpret as they wish. So as a result, he's completed all necessary medical procedures to fully transition from female to male. And that's true because some people don't need surgery. And my understanding of this care, my professional understanding of this care, this is a true statement. He should be considered male for all legal and documentation purposes, including all these different things. Now, I may know that his birth certificate in whatever state doesn't allow that, but this is still a true statement. He should be considered male because guess what? Your birth certificate requirements are kind of screwy and bad. So you write the letter that your patient needs. Don't worry about the gender cops because they're not going to come and get you. If you have questions about that, email me. You can also email the or go to Transline if you have specific questions about patients. Again, the clinical protocol's there. Does anybody have any questions? We have 2 minutes left, I think. So I do have a question. So I have a transsexual woman after surgery years ago whose insurance denied coverage for hormone therapy. What buzzwords do I need to get coverage, or do I generally need, or do I generally need N to see the patient and, oh wait, hold on, I can't see the rest of the question. See the patient and recommend dosages. So, well, the easiest way is put them on something cheap and she can pay for it herself. As long as your visit is for something else, she's there for asthma and to do her hormones, the insurance is not going to deny the asthma visit. The thing is now in California, if she has Medi-Cal, Medi-Cal pays for it. Contact the Transgender Law Center. If she has an HMO, a PPO, old-fashioned insurance, anything that is a California product and regulated by the Department of Managed Healthcare and the Department of Insurance, call the Transgender Law Center because this is exactly what those two agencies put out policy to prevent. Now, it doesn't mean this is going to be easy, but you can do that. The other thing too is when you're trying to get the authorization done, I've even written, this person is trans, according to this, you have to pay for it now, and especially if you're getting something like inexpensive, like, estradiol by mouth, they're usually fine with it. Any other questions? I hope that answered your question. You can also just talk if you want to, if you're not on mute. So with 60 seconds left, it looks like there's no other questions. Thank you all for coming. I really appreciate the chance to talk to you. And if you have any other questions, let us know on the Transline.
Great. We thank you for doing that presentation for us. We'll go ahead and close out the webinar right now if nobody has any other questions. Great. Okay. Well, everybody have a good day.
Great. Thanks for having me.
Thanks. Bye-bye.